Assalamu alaikum wa rahmatullah, everybody, and welcome to the next webinar that we're holding on the different topics of bariatric surgery. Welcome all of you. It is actually now time to get started, but I can still see some participants coming into the entering into the room right now. So we'll just give them another couple minutes and get started. I'd like to thank all of you for taking out the time and participating. And I look forward to having a fruitful discussion at the end. I can see a number of names showing up, friends that we know each other from Saudi Arabia as well. Thank you so much for coming on board. We're actually going to be conducting a poll in the beginning just to get an idea from the audience on how to conduct the rest of the discussion for the meeting. And so I'm hoping that some more participants can come in so that the poll can be, we can have some good results on the poll. So we've got approximately 23 people who've joined. And give it just another minute or so, and then we'll get started with the polls. So I hope you can all hear me. If anybody can just send a quick message on the chat box to confirm that. Okay, great. Thank you so much. Thank you. Wa alaikum assalam wa rahmatullah. Wa alaikum assalam wa rahmatullah. Thank you all. Wa alaikum assalam. Thank you. Okay, excellent. All right, in that case, we'll get started now. All right. Bismillah ar-Rahman ar-Rahim. Wa salatu wa salamu ala rasulil kareem. Okay, yeah, we've got suddenly a bunch of attendees who just came in right now, all of a sudden. All right. We'll get started now. So as we've said, we're going to be conducting a few polls in the beginning. And so, here we go. So we'll have the poll, and then we'll review the surgical management of certain complications. So this talk is primarily geared towards the surgical complications and how to manage them surgically and the principles of management, and how to avoid them, because a lot of these complications could have been avoided during the first surgery. And so we'll look at a few of the technical details that could help us avoid these kind of complications from happening. What we'll also be looking at in the next session is the endoscopic skills. And I really encourage all of you to talk to your gastroenterology friends to attend the next session. It's going to be an awesome session talking about the complications, managing these complications endoscopically. We have a star speaker, Dr. Imad Abdullah from Egypt, who does a lot of different techniques, including endoscopic septotomies and internal drain placements, for managing these kind of complications very successfully without having the need to do any surgeries. And I hope that we can all benefit from those skills, and that's why I've asked him to present those techniques to us, and he's generously accepted the request. And the last session will be in approximately, I believe, so the next one is going to be on the 8th of May, and the last one is going to be on the one second, I need to close my clinic room. Sorry about that. In the middle of clinic, and I've asked my secretary not to send any patients, but okay. All right, so the last discussion webinar on this series will be on the 12th of May, and it's going to be looking at nutritional complications. And we have a wonderful speaker from Singapore, Dr. Asim Shabir, who will be looking at nutritional complications. So I do encourage you to have your medical friends join in, primary care physicians, general GPs, and medical internists, endocrinologists who'd like to know how to handle those kind of nutritional complications that can occur from sleeve gastrectomy and other bariatric surgeries. Okay, so now let's get started with a poll. So the first poll question, and I will, so Hamad, do I have to press the launch poll button from here? Or you can do that? Okay, good, Hamad is doing that.
Yeah, you can do that. You can do that. You can. Yeah, you have full control over the polls.
Why didn't you launch the poll? I don't want to deal with that part.
No, I can't. I can't.
Okay, you're testing my skills, aren't you? Okay. Here we go. I've launched the poll. Do you all can you all see the poll questions appearing on your screen? I will speak a little louder. Somebody's asked me to speak a little louder. I'll try to speak louder than this. And do you all see the poll questions popping up on your screen? Good, excellent. Okay, so poll question number 1 is the following. What clinical feature is the most commonly associated with a leak complication after sleeve gastrectomy? Is it abdominal pain, tenderness, tachycardia, dyspnea, or fevers? And you can click on any of those options that are visible to you. So you can just click on the option directly. If you're using your phone, you can click on the phone on any of these options, or if you're using your laptop or desktop, just use your mouse. So I'm going to give you all 30 seconds to answer this question. So you can just click on the option that one of the choices. Has anybody tried clicking on them?
Dr. Tahir, can you make me the host? I'll fix something is wrong with the polls.
Okay, how do I make you the host? That's a good question.
Right click on me. Right click on me.
Yeah, go ahead. Okay, I'm going to make you the host now.
Okay, let me.
Sorry,
okay, relaunch poll. Okay.
Glitch. We'll fix it right now.
Okay, so the poll is live now. Yeah, they can start.
Sorry about that. Go ahead and answer the first question now. Try it now. If anybody's been successful, just send me a message. Okay, good. Okay, so go ahead and answer the first question. We'll give you another 10 seconds on that. $30 seconds. So now, what do you call it? Hamad, they're saying that they can answer, but they cannot submit it.
Can you make me the host again? I'll see. It should work. It should work without even submitting.
Or do they have to answer all the questions and then submit?
I think, yes, they have to answer all the questions.
Okay. All right. Well, we'll just move to the next question and keep submitting your answers. So just click on the choice, the option that you feel is the most appropriate for question number 1. We'll go to question number 2, then you answer that, and similarly all 5 questions. We'll see the results at the end. Sorry about that. But Hamad, we need to next time make each question an individual poll.
Okay, okay. And the next time I'll have individual answers. Okay.
Sorry about that, everybody. We're still learning how to do these things over here. Okay. So poll question number 2, a male patient with a BMI 50 comes to the emergency room 9 days after a successful sleeve gastrectomy surgery. Patient's pale, diaphoretic, complaining of recurrent emesis, dark stools, has mild abdominal pains. Patient's temperature is 39 degrees Celsius, tachycardic, 130 per minute, dyspneic with a respiratory rate of 28 per minute, and has a soft abdomen. You start IV fluids, you check his CBC, white cell counts elevated, hemoglobin slightly dropped. What's the best next step? So is it an upper GI study, endoscopy, IV antibiotics and admission to the floor, a CT scan, or ultrasound abdomen. Give you another 10 seconds on this one, and then we can go on. All right. Go to the next question. Poll question number 3. Which of the following statements is the most accurate for radiological tests in diagnosing a sleeve gastrectomy leak? Is it CT scan has a high sensitivity and high specificity? Upper GI fluoroscopy has high sensitivity and high specificity? CT scan has high sensitivity but low specificity? Upper GI has a high sensitivity but low specificity? MRI is the study of choice in diagnosing leaks. And I understand that some participants are having trouble answering, or maybe everybody is. And it's the flaws from our side in trying to create the design of this poll, but we'll review everything at the end anyways. So we'll just go, because we spent a lot of time on the first 3 poll questions, we're going to go through the other ones relatively quicker. Okay, poll question number 4. A 42-year-old female patient comes to the OPD 4 months after a sleeve gastrectomy. Weight is dropped suddenly, over 4 months has dropped dramatically from 120 to 80 kilograms. BMI has gone from 50 to 33. You are very happy with the good weight loss, but she is depressed and she's complaining of dysphagia with all semi-solid foods. She only tolerates sips of liquids, has recurrent emesis, of white frothy sputum. She feels very weak, looks pale. Her vital signs are stable. What is the best study to diagnose her problem? Is it a CT scan, endoscopy, upper GI study, X-ray abdomen, or an MRI? Okay, we'll go to the next poll question. You diagnosed a patient with a mid-body stricture of the sleeve gastrectomy using barium contrast mixed with cornflakes. What is the best next step? Do you want to convert to a Roux-en-Y gastric bypass, convert to a SASI operation, do an endoscopic dilatation procedure, endoscopic stent placement, or have a jejunal feeding tube? All right. Why don't you answer this one, please? And you might find a submit button at the end. You can submit it. We can look at all the results. Hamad, you're going to handle the poll at this point?
Yeah, like 50% of the people have submitted. I'm going to wait till like all of them answer.
Give it another 20 seconds, 30 seconds.
Yeah, okay.
Okay, why don't we share the results?
Okay, let me share the results. Sharing the results now. You should be able to see it.
Okay. So great. So now, I hope everybody can see the results. So a lot of people agree that tachycardia is the most sensitive or the earliest clinical finding when somebody has a leak complication after sleeve gastrectomy, and that is correct. So there's, for question number 2, so it's a male patient with a BMI 50, comes 9 days after a successful sleeve gastrectomy and has recurrent emesis with high temperature, sepsis, despite a soft abdomen. And so what is the best next step? So some feel that it is an upper GI study. Others want to go for an endoscopy, IV antibiotics, admission to floor. CT scan is where the majority feel is the most appropriate, and an ultrasound abdomen. Okay, so this patient has what we have the suspicion of a leak. And even if it's not a leak, if it's something, it's a serious surgical complication. And the patient's unstable, is in sepsis. So you probably want to find out exactly what's happening before we can send him to the floor or to the ICU, wherever is required. And the best study to give you that information is going to be a CT scan over here. And we will review some of this on the next few slides during the talk. Which of the following statements is the most accurate for radiological tests in diagnosing a sleeve gastrectomy leak? So a CT scan has high sensitivity and specificity is the correct answer. Upper GI fluoro is specific, but not sensitive. So there are a lot of patients, you will get false negative results, and they have an ongoing leak, and the upper GI study is going to be falsely negative. But if it is positive, then definitely you have a leak. So this upper GI study is not a very sensitive study. A CT scan is sensitive and is specific. We'll go to the next one. Okay, a 42-year-old female patient comes to the clinic 4 months after a sleeve. Yes, there's a dramatic weight loss, but the patient's not doing well. Nutritionally is getting malnourished. You can see that. The presentation is malnutrition, and it's obviously probably from a stricture in the stomach because she cannot tolerate any solids. And so an endoscopy is a very valid option, and so is an upper GI study. Both are very good options in diagnosing it. A CT scan can sometimes miss strictures. It's not very good as at diagnosing strictures, and neither is an MRI. So you do have a stricture, and so the majority want to go ahead with endoscopic dilatation, and I think that's a very valid option because you can do an assessment and a dilatation at the same time. And an endoscopy is always required prior to converting to a bypass. So while you're doing the endoscopy, you might want to even consider a dilatation before subjecting the patient to a surgical conversion. Okay, good. So now let's go to the talk. So the first complication, so there are three main complications we're going to be reviewing. Surgical complications, we're going to talk about bleeding, stenosis, and a leak. So bleeding can, occur while we're from any of the surgical sites, especially when we're dissecting the blood vessels along the greater curvature or in the posterior gastric vessels. As the higher you go up on the sleeve, the more it gets difficult to expose those vessels properly, and the chances of not being able to control them appropriately. Similarly, while stapling, you can have bleeding from the staple line that may occur in front of you or later on, and it could occur intra-abdominally or intraluminally. Splenic hinum or splenic injury can occur, and you can start having bleeding from any of that. The bleeding might be identified intraoperatively, or it could occur during the recovery phase. And then post-operatively, the patient could also have bleeding from any of the port sites. So once you remove the ports, they start bleeding intra-abdominally or even subcutaneously, especially in patients who have a lot of subcutaneous fat, and the fat is not good at tamponading the subcutaneous veins, and that could end up having bleeding. I do prefer using an advanced bipolar device for a sleeve gastrectomy. I've found that they do have better hemostasis control of the short gastric vessels, and a lot of the surgeons feel the same way. One thing to note is that the thicker the omentum gets, so a lot of the studies that have been conducted in an ex vivo condition for assessing the ability of these devices for providing hemostasis are done with bare vessels. So you don't have any fat around those vessels when they're doing those studies. And so you look at burst pressure and hemostasis with those vessels using these devices. But in reality, when you're doing it, you actually have a lot of fat covering those vessels, and the fat tends to spread the energy and it diffuses the energy. And so you don't get all that energy delivered onto the vessel for sealing it. So that is something you have to keep in mind, especially when you're dealing with a mental fat. And so what I do is I tend to burn away from the stomach and then closer to the stomach. So you go proximal on the vessel, distal on the vessel before cutting it. And some agree with that, others don't. I do recommend that you keep an eye on the jaws of the instrument, because you can have collateral damage from the instrument, especially a harmonic device. The active blade is quite dangerous. And if you're not keeping an eye on it, it could potentially damage, especially as you're getting near the GE junction. You could damage the esophagus, and we've seen cases of leaks as a result of that. Okay, so how do you control this bleeding? So the most important thing in any bleeding control is apply pressure, and you can do that immediately using the instrument, the surgical instrument that you have available. Okay, recordings will be available for 24 hours. At the end, everybody registered will get a link. Wish you the best. Hope your patient gets well. So you could control bleeding with the instrument, or you can insert a gauze. But if you do start inserting gauzes, make sure you keep counts. The gauzes are good for providing, initiate the coagulation process. Other options are using a metallic clips or a bipolar device. Bipolar devices are safer than monopolar devices because the energy does not go to the patient, it remains between the jaws of the instrument. If the bleeding is from the staple line, you might want to apply the clips or apply stitches. And other options are hemostatic material, which could be oxidized cellulose or fibrinogen, whichever one's available and handy in your institution accordingly. But I tend not to leave these materials inside a patient, especially if they're woven into some sort of fabric, such as Surgicel, because I've seen patients develop abscesses as a result afterwards. So the bleeding might occur postoperatively, and while the patient's on the recovery unit or on the floor. And the occurs primarily because you have a lot of empty space. So you remove the huge stomach, and the omentum has been separated from the stomach, and it drops down into the lower abdomen. So you have this empty space in the splenic fossa that can accumulate up to 1 to 2 liters of blood with just any venous ooze. So just a mild ooze can end up having a lot of blood loss over there because there's very little pressure to tamponade this. But the patients typically present with a lot of tearing chest pain. So you will notice that these patients are going to have a lot of severe chest pain. They're going to say, we have this tearing chest pain, and they're going to put their hands like this, that we feel this tearing chest pain. And they're going to look pale, they're going to have cold hands, they might be diaphoretic. The problem is that most of these symptoms occur within the first 24 hours, and it's a little difficult to diagnose it because you've been giving a lot of pain medications. Patients are a little drowsy from those pain medications and from the anesthesia medications. And then if you start checking a CBC, the hemoglobin doesn't drop, rather it takes a while to show the change. And tachycardia is also not always there because you're giving them a lot of IV fluids. You're giving them IV fluids during the surgery. You're giving them after surgery. The anesthetic medications, a lot of other things working. So you might not even have tachycardia. And then I've had a case where a patient in the recovery unit had 1 or 2 liters of bleeding, but the drains were blocked, and gave me a false sense of security that, oh, it's serous fluid coming out of the drain. And the patient had already bled 1 or 2 liters in the recovery unit. So all of those things are possible. Omentopexy is an option, but you still have a lot of empty space. And there's, we can only talk based on experience over there. So what you need to do, you have to be suspicious. Check because there's a lot of chest pain involved, and if the patient is diabetic, hypertensive, near the age of 50 or above, you might want to check an ECG and make sure your cardiac enzymes are not elevated because it could even be a postoperative MI. At the same time, while you're drawing those enzymes, you might as well check a CBC. A quick thing that you could do if you're concerned is to get an ultrasound of the left upper quadrant area, just like what we do like a fast exam, and you look for fluid around the spleen itself. And that's a quick way to tell you if there's any fluid accumulating around the spleen, then you might want to be considering that it could be an intra-abdominal bleeding. And if you have the luxury of available of just getting a CT scan, then that would be an option as well. So how do you control post-operative bleeding? So most of these bleedings do settle down on their own and can be managed conservatively. Checking serial CBCs, giving some blood, giving up to 2 or 3 units. Try not to go too much above that to maintain a hemoglobin. And if you're needing to do that, you probably need to explore the patient. Remember that all this blood that's accumulating inside the abdomen will eventually end up coming out in the form of a bruise on the abdominal wall. So you have this extensive bruise across the abdominal wall with a bluish color, especially at the sites of the incisions. And these incision sites will accumulate a lot of blood underneath them. Eventually, the patient might come at 10 days or 12 days to the emergency room with oozing clotted old blood coming out of those wounds, and you might end up expressing a lot of old blood. So constant reevaluation. If you're going to be doing conservative management, keep reevaluating the patient and have a low threshold for re-exploration. Though most explorations are negative, because by then the vessels have tamponaded and they've stopped bleeding. But the benefit of an exploration is always that you have an opportunity to remove this large volume of clot that's collected inside the abdomen. And if there are any bleeders, you get an opportunity to control them. And remember that these hematomas that accumulate inside the abdomen may actually is a perfect culture media and can develop an infection or an intra-abdominal abscess. The bleeding can also be a sign of an early leak. And so when you're exploring the patient, you might as well do a leak test. You might want to consider doing an endoscopy and insufflating the abdomen, insufflating the stomach with a clamp on the distal bowel and seeing if there's any air leakage. But remember, leaks are not always seen even on intraoperative testing, and you might get this false sense of security. So it's always better to leave some drains next to the stomach. If you haven't even identified a leak, that there might be a possible leak or a micro leak that might present itself later on. So leave some drains over there just to be on the safe side and control the situation, avoiding a re-exploration again. All right, so here is a video, and I'm going to, the credit of this video goes to Dr. Waleed Bukhari. He's a senior colleague and a friend of mine, and I asked him, he had this wonderful video that I'd like to share with everybody, which shows the large amount of blood that it can accumulate inside that splenic fossa, as I mentioned earlier. And as you can see, this patient was taken back from the recovery unit, so it's barely like 2 or 3 hours after surgery. And when you go in, you find this excessive amount of blood, and you're trying to control it. You're using different techniques, oxidized cellulose. You're putting stitches, trying to hold it with whatever techniques you can have available to try to control the bleeding. And but you have to make sure that the bleeding has stopped. So once you're checking everything and you find out that there's still blood accumulating, keep looking for this potential site, even if it means that you have to open up your gastropexy stitches. And there it is. It could be one of those posterior blood vessels, posterior short gastric vessels that I mentioned earlier. Then how do you control them? Then you, of course, apply pressure with an instrument, try to get control of the vessel itself. You may want to consider, using thermal energy. So having good suction and irrigation is key here. So it's extremely important to have good suction and irrigation to control it. So here is, he's grabbing the vessel and then applying some thermal energy directed specifically at the vessel. You have to be careful that you're not going to, so you can see how the left hand is pushing up the stomach. That's important, so you're not going to burn the stomach. So you're only grabbing the fat. And if it doesn't get under control, you might want to consider putting a clip or getting a stitch on the control it. There it is. So it's finally controlled with a clip. Okay. So the other potential cause of bleeding could be from splenic injury, and that could be from traction injury or even from an instrument trauma, especially in elderly patients. You have to remember that their splenic capsule is quite delicate and friable, and if you're putting some traction on the omentum to try to gain access to the gastric fundus, you may end up tearing the capsule. And the injury can also occur when you're inserting the left upper quadrant optical port at the Palmer's point. So when you're inserting under a visi port or an optical port under direct vision in the left upper quadrant area, and you're just underneath the rib cages, and you're just going underneath the ribs and you're directing towards the left upper quadrant area, that port itself could injure the spleen, especially if you have splenomegaly. So if you have splenomegaly on the ultrasound of the abdomen, you might want to consider putting your port, left upper quadrant port a little lower than the ribs, a couple finger breadths lower than the ribs, and be careful when inserting it. Don't push in too much. And if you do injure it, don't spend time looking at it from that same port. Immediately get other ports in so you can control that bleeding. Pack with a lot of gauze or any hemostatic material and apply pressure. You might want to consider using bipolar energy because it is able to burn between the jaws. Really, you might want to consider splenectomy. And if it's severe, you might want to even open the patient. And here's another video from Dr. Walid Bukhari, where he was doing a removal of band, conversion to sleeve. And as they were removing the band, they encountered a splenic injury. And you will see the different techniques that we mentioned over here being used to control that bleeding. And first of all, so there's some bleeding going on, and you can see how he's applied a lot of hemostatic material. He's trying to control it. He's trying to gain access, find out exactly where's the size of bleeding. He's going to apply some more gauze over there and some pressure, apply some pressure with some hemostatic gauze. So it's a capsular injury. These capsular injuries are very difficult to deal with, and especially in the hilum, you might have a vessel that's retracted backwards into the hilum. It's difficult to gain control of. So once you've packed it, you might then eventually consider splenectomy. And this is what he's doing. He's putting a stapler across the splenic hilum and doing an intraoperative splenectomy to control the bleeding. And that's one of the options that you have to consider to control that bleeding. And so there he is. He's controlled past the stapler once, starting to suction and see if he's in control. If needed, he's going to put another stapler, complete the splenectomy. And there we go. You can see how he's using a white load, of course, vascular load. And completion of the splenectomy. And of course, he considered this after spending a lot of time to control that bleeding, but all options failed. And so at that point, this is one of the options that he had to consider. And now you can see that the bleeding has stopped, and eventually at the end of the procedure, he had to even remove the spleen. Okay. So moving next to the next complication, which could be stenosis. Stenosis can be acute or chronic. If it's acute stenosis, the patient is going to have immediate postoperative oral intolerance and a lot of salivation. Saliva is just going to start drooling from the mouth. And if you do an upper GI study, as shown in the picture over here, you might see gastric outlet obstruction. And the reasons are that what could be from applying the stapler too close to the bougie, especially at 2 points. So I keep telling my trainees that there are 2 points you have to be careful: angularis incisura and angle of Hess. There are 2 angles. Make sure you're not too close to the bougie at these 2 angles, because these are the points where you end up having a stenosis. So keep a little bit of space from the bougie at both the angularis incisura and at the angle of Hess at the cardia. And if you tend to oversew the stapler line, so some people like to oversew the stapler line, especially Lambert sutures, so you have to maintain a little bit of space away from the bougie, because when you're oversewing and you fold the gastric wall, you're actually going to make it compromise the lumen even further. And if you're doing that at the angle of Hess or at the cardia and it's already compromised, then definitely you will end up having a lot of stenosis over there. Do not do an endoscopic dilatation. The stapler line will break down. If you have to give it some time to heal before considering that as an option. Chronic stenosis. So the patient's going to have, once the patient's coming into the semi-solid phase, which is after the first month, they're going to start noticing that they're having difficulty swallowing the proteins, especially proteins. Fish, meat, chicken was going to be a little difficult. They're going to start telling you that, we keep having to cough and this frothy sputum comes out into our mouth and we have to sort of spit it into a tissue paper. We always carry this tissue paper and we're spitting into it and we feel weird. And in addition to that, they're going to start complaining of a lot of epigastric chest pain, especially when they're eating dysphagia, and they're going to have GERD symptoms. So these stenosis, especially if it's mid-body stenosis, end up having a lot of GERD symptoms. They start having this dehydrated, pale, sick-looking patient. And because you have a stenosis, and the only thing that can go through it is something that can slip through it. So carbohydrates, such as crackers, chips, and ice creams and chocolates, especially when you take crackers and chips with some sort of a liquid, tend to become a paste, and they slip down even the narrowest of lumens. And so the patients are, they get this crave to eat something because they're not able to eat anything, so they're looking for some sort of nutrition and calories, and that's how they start looking for crackers and chips and chocolates. So they start getting afraid of eating chicken, meats, fish, fruits, and vegetables, which are difficult to pass through the mid-body, and so that's why they get protein deficient, sarcopenic. If you check their muscle mass, it's dropping down. They start avoiding social gatherings because they keep having to spitting out the food, so they don't even go out to meetings. They avoid food. When they go out, they just don't eat. They start feeling depressed. They even can get suicidal. They end up becoming grazers. So all day long, they're just grazing on some sort of carbs, which ends up having poor weight loss as well. So when you do have chronic stenosis, as is shown by these pictures, it could be from a number of reasons. Number one, most commonly it's from excessive traction while stapling. And this traction, if it's occurring at the lateral traction, so when you start stapling the stomach and you're applying lateral traction at different points. So you apply lateral traction. You cannot apply lateral traction along the whole cartridge length. So you apply lateral traction at one point with your instrument, and so one point at the cartridge length becomes pulled outwards, and the rest of it is not being pulled outwards. And when you staple, that point that was being pulled outwards goes inwards, and so you get a zigzag. So you start getting a zigzag up and down sort of a staple line. And if you're doing a lot of posterior wall traction, you start ending up getting a corkscrew, so a spiraling sort of a staple line. And this can end up having a mid-body stenosis, just like what's shown in the barium study over here, which is what we call an hourglass stomach. Endoscopy is a very good tool, but it's not always diagnostic, because once you insufflate the stomach with endoscopy, you can open up the lumen, and so the stenotic area may not be visible. However, endoscopy is a very important tool to assess the degree of stenosis, because you might find stenosis at one point, which is either the angularis or cardia, or it could be just a spiraling sleeve at the whole length of the stomach, making it difficult to pass the scope through it. One of the best ways to study a stricture and to diagnose a stricture is what we call a dynamics upper GI study. So you do a dynamic study, not so you need cineviews. You do need cineviews, and you use thick barium, and you can get thick barium by mixing it with cornflakes or isparol or whatever you like. Make your barium thick, and have the patient take spoons of the barium and notice how it gets where are the points where it gets stuck, and make sure you get two views. So AP and lateral. So how do you avoid stenosis? So somebody's asking about technique as well. So that's why we're talking about technique with complications, so that we know what are the things to avoid during our technique. So when you're inserting the bougie for doing the sleeve gastrectomy, make sure your bougie is not pushing against the stomach. So if you insert the bougie and the bougie reaches the antrum and you start pushing against the antrum, what happens is that you've stretched the stomach, and when the bougie is retracted, the accordion effect happens, and the stomach sort of gets shorter. And so you can get a stenosis at some point in the middle as well. And you have to avoid lateral traction when you're closing the stapler device. So when you can apply traction to pull the stomach out and make sure that there's no leftover stomach or no excess stomach on the side of the sleeve. But once you've done that, before you close the stapler, make sure you've let go of that traction. So don't close the stapler while you're applying traction. And make sure you orient your stapler. So there are two jaws of the stapler. Make sure you've oriented the stapler parallel to the stomach wall. So the jaws of the stapler should be parallel. It shouldn't be like this, or it shouldn't be like that. So you're leaving more posterior wall, or you're leaving more anterior wall. Staple along the same line. Make sure you're stapling along the same line. And at the end, you may want to just have your anesthesiologist pull the bougie outwards and inwards and see how it goes in and out of the stomach, and tell you if it goes in and out smoothly or if there's any stenosis. Some people use gastropexy stitches. So what they do is they take a stitch of the omentum and they fix it to the staple line and holds the staple line in a particular orientation to avoid it from getting stenosis later. But when you're doing those stitches, make sure you don't take a deep mesocolic stitch, because if you take a deep mesocolic stitch, remember you have your duodenum and your jejunum below, and we've seen cases where we've had obstructions from that stitch specifically taking a bite of the jejunum as well. Okay, so ended up with the stenosis. What are the options for management? And you can see this picture over here that's showing endoscopic dilatation, but let's look at what you have to do if it's acute. So if there's an acute stenosis and it's immediate post-op, you do not want to do an endoscopy right now. If you want to wait, the options are inserting a feeding tube. So if you and your patient can wait 6 to 8 weeks on a nasojejunal feeding tube, that might be a consideration if you can insert the nasojejunal feeding tube comfortably without injuring the staple line. But that is usually not the case. And the only option that ends up is doing a surgical revision with conversion to gastric bypass. So that should be something that you have to consider at some point in your discussion with the patient. If it's a late presentation and the patient's having stenosis entering into the solid food phase, that is when you want to consider endoscopic dilatation at 2 months. The dilatation is done using a variety of different techniques, but the most common one is an achalasia CRE dilated balloon. It's going to be gradual and progressive. Hopefully, in our next session, we're going to look at endoscopic management of stenosis as well. But it usually does require about 2 to 6 different sessions. And one option that's emerging right now in the different meetings is what we call endoscopic myotomy. It's still, it's not a technique that's widely universally done, but it is an option as well. And then if everything fails, eventually you have to convert to a gastric bypass procedure. Okay, moving now over to leaks. So leak is the dreaded complication of sleeve gastrectomies, and recent large studies have shown that it is now about 0.5% of sleeve gastrectomy cases end up having leaks, regardless of which institution and what technique is being used. But higher rates are seen in cases in centers where there's less than 100 cases per year, or where there's an early learning curve, and in cases where patients are having revision surgery or a BMI above 50. Mostly the leaks occur at the esophagogastric junction or the GE junction, but it could occur at any point on the staple line as well. Leaks can present less than 10 days, are called acute leaks, or more than 10 days with an abscess. Technically, it could be because of stapling against the esophagus, or from a stapler cartridge malfunction, or from wrong staple choices. And somebody mentioned the staple or correct stapler selections, and I agree, it should be black or green at the antrum. Avoid going to narrow, shorter stapler heights, though you may want to consider taking a gold or a blue cartridge near the fundus, because the stomach tends to be a little thicker in the antrum, and as you go up, gets thinner. Other causes could be ischemic, so a lot of dissection at the EG junction, which is a watershed area, and you end up taking down a lot of the blood vessels. Though it is important to expose the left crus of the diaphragm when you're doing a sleeve gastrectomy and you've completely liberated the fundus, that is an essential task, but at the same time, you want to make sure that you leave the blood vessels that are coming in from the lesser curvature. And as I mentioned earlier, it could be from thermal injury, using your device in a way that the jaws could be injured. The presentation. So it's a perfect storm. It's what we call the perfect storm, and it's one of the things that the surgeon dreads the most, because your sleeve gastrectomy is a narrow tube, and by law of Laplace, as the diameter and the radius get low, the intraluminal tension and pressure go up. So you have a lot of high pressure, and it's been proven with a number of studies that the sleeve gastrectomy has a high pressure inside the lumen. And you have a pylorus at the end that's creating a partial obstruction as well. And you don't have omentum outside the stomach because you've dropped all the omentum down after separating it from the stomach. So you have very little pressure outside the stomach and a high pressure inside the stomach. And so if you have a leak, this fistulous opening is definitely going to get worse. And then the kind of effluent is also quite aggressive. I mean, acidic effluent, and it's going to very critical areas, going to the pericardium, entering into the mediastinum, going to the splenic fossa, to the splenic hilum. Patients end up having tachycardia, dyspnea, chest pain, potentially bleeding. And always one of the common things that you'll find from these patients is that they have this feeling of doom. So they feel as if something is really not right on the inside and they don't feel good. Some do present with left-sided flank pains and tenderness, but it's not very common. And so don't keep looking for that as a sign of leak. Rather look at the other subtle features. Fevers do occur, but not always. Very high BMI patients do not present with fevers. Younger patients do tend to have fevers. And so if you have a super obese patient, it could be lost with a clinical presentation. So how do you diagnose it? Lab-wise, CBC is not very indicative. So you do not have to have leukocytosis and have a terrible leak or an intra-abdominal abscess. CRP is a much more sensitive marker, and the best thing about the CRP is that it can be used as a prognostic marker. So once you've dealt with the leak, or you keep following your CRPs, you can see how it's trending downwards to show that the patient's getting better. But the study of choice is actually a CT scan using both IV and oral contrast. And it's important to use both of these. As you can see, that it has both high sensitivity and high specificity when you're using them. Upper GI studies are good, are specific, but are not sensitive. And one thing I keep hearing from different surgeons is that there was no contrast extravasation. Well, there doesn't have to be. And studies have shown that 70% of CT scans do not have contrast extravasations. And so you do not have to look for contrast extravasation. Rather, you look for the subtle signs. Is there fluid or air loculi at the esophagogastric junction or in the mediastinum? Is there fluid or air around the splenic, around the spine or within the splenic hilum? And so if you have, and I teach my trainees the same thing. You have three decision makers. You have clinical, biochemical, radiological. If any two are against you, you have to be suspicious. So if you have some abnormal CT scan finding and abnormal labs, even if the patient looks fine, be suspicious. So this is what a CT scan may look like. And the reason I brought this up is to show a couple of features of the CT scan. So one, you can see that this is the stomach itself, and this is the staple line. So the CT scan tells you if your staple line is in good orientation or is it zigzag or spiraling. It does give you that sort of an idea. What you can see is an air fluid level here with contrast outside the stomach. And there is an air fluid level with the contrast. But you can also, this may be colonic gas, or it could be free air within the omentum, and as well as this one. But this is definitely an air loculus around the spleen with a lot of fluid around the spleen as well. So these are some of the findings that you might have. And so you want to start off with IV fluids, IV antibiotics, antifungals. Antifungals is something we tend to forget. Make sure you give that because these patients do develop intra-abdominal fungal infections. Broad antibiotics with antifungals. The CT scan will show you the fluid collections, will show you the leak site, will show you the gastric anatomy, if there's any pleural effusions. And always check for portal vein thrombosis and splenic abscess. And so do the phasing according to the contrast phasing accordingly. So if you have an unstable patient, even if you've resuscitated the patient is still septic, you have to do a laparoscopic washout and place some large drains. At the same time, when you're doing a washout, you have to assess where is the leak site accessible or not. And usually it's a little difficult to access, but at least you get an idea. You take an idea of what about the rest of the abdomen looks like. If I need to do a Roux-en-Y fistula duodenostomy, what are the barriers I will face? How is the patient's status? Is the patient capable of undergoing another procedure at this time? Is the patient hemodynamically stable? Will they tolerate the procedure? Is my OR equipped to support my needs to do this procedure? And do I have that technical skills? But while you're there, make sure you do take some cultures. These cultures are the most important cultures to guide future treatments. And so when you're doing, when you take these cultures, they help guide your antibiotics for the rest of the course of the admission. So always take cultures. It's extremely important to take those cultures. So your options at this time, once you've made those assessments, are either you're going to do a Roux-en-Y fistula jejunostomy if it's possible, do a washout, complete washout, and then make sure that you don't have any distal obstruction, whether you can do that with the bougie or doing an intraoperative endoscopy. One thing that has panned out from a number of studies, and a recent study by Dr. Motaz Basha, who looked at 73 leaks and gave some nice findings from that study, including the CT scan findings that I mentioned, is that the patients who end up having jejunostomy feeding tubes heal up very early. So leak patients, on an average, take about 8 weeks to heal up. 8 weeks. So it could be anywhere from between 3 weeks to up to 3 months. And the average is about 8 weeks for healing up. And during that time, if you need to give them TPN on a daily basis, it's going to be very costly, and it could be also have a lot of potential complications, infection complications, other metabolic complications as well, gallstones development, and a lot of other issues. So if you can get jejunostomy feeding tube, it's number one, you avoid all those complications. It's much cheaper, it's much easier to handle. Patient doesn't have to be in a hospital, and they heal up much rapid. I mean, they found that jejunostomy feeding tube patients healed up within 2 weeks. So this is a video that shows you what is the situation that you're facing when you're entering a case with a leak. You're opening up all the cementum, and as you reach the GE junction, you suddenly find this gush of pus. That is when you want to get your culture. Make sure you want to get your culture at this point in time. Okay. Okay, so what about a stable patient? So you've diagnosed that the patient has a leak, but the patient is really stable. Now what do you do? So for one, there's CT scan, again, to assess the anatomy and the leak. And at that point, you might want to consider putting a radiological drain. If you do successfully get a radiological drain by interventional radiology, make sure you send a culture and check an amylase level. Because if it's an abscess, you've drained it. If it's a leak, amylase levels is going to be very high in the thousands. So this way you can differentiate between hematoma, abscess, or a leak. If it is a leak, then because you don't have any feeding access at this time, so get a PICC line or a central line and start TPN. Do an endoscopy to assess, and this is one of the endoscopic pictures of fistulous opening. And you also get to see if there's distal stenosis or a twist. And potentially you might want to consider placing a stent, but that will be covered in our next webinar. So what are the tips for when you're doing an operative exploration for a leak? So when you do your sleeve the first time, try to choose port sites that are going to be used if you need to explore the patient again to handle the leak. So your port sites should be favorable for you to take care of a leak by doing a washout, placing drains, and if you need to do a gastric bypass. Otherwise, you will end up putting additional ports in different parts of the abdomen and a lot of multiple scars, multiple wounds. You definitely need to make sure your nurses arrange for good suction and irrigation from before the procedure, and make sure you have a lot of warm irrigation because you're going to be using it copiously. Make sure you have your culture specimen trap available before getting in, because you end up seeing that pus, you don't have the trap, and they go running around finding the trap, and you lose pus by that. Patients, you have some PRBC units available. Keep a laparotomy set in the room with a liver retractor if needed. Do gentle exploration. So don't be rough, just keep irrigating and use blunt dissection and you'll be able to get access, but just go slow and easy. Send your cultures and place a large drain. Once you've cleaned it all up and you want to do you place your drains, you might want to consider putting a jejunostomy feeding tube at that time. It's not a difficult process. It's very straightforward. You look at where the ligament of Treitz is, measure about 50 to 70 centimeters from it, because that is going to be a potential site for potentially transecting the jejunum if you need to do a Roux-en-Y fistula jejunostomy, or for any reason a Roux-en-Y anastomosis. So the Roux limb will be created at this point. So that's why 50 centimeters from ligament of Treitz. Make sure you orient your bowel and you know where is the distal end of the bowel. Put a purse string suture and insert your feeding tube through the abdominal wall. It could be a 12 or to 14 French Foley tube or a Nelaton's catheter, and direct it towards the distal end. Make sure you do a Witzel closure after closing the purse string and avoid stenosis of the lumen of the small bowel. Once you've done that, attach the small bowel to the anterior abdominal wall, both proximally and distally, so it doesn't twist around the tube. We've seen cases where the small bowel twists around the feeding tube as well. And make sure you test your tube. If you're planning to do an endoscopy, insert the jejunostomy feeding tube first and clamping the bowel during endoscopy so you don't insufflate the whole small bowel with air while testing the sleeve. If you're not able to do any of that, then consider placing a nasojejunal feeding tube at least and fixing it to the nose. Okay, if you decide to do a Roux-en-Y fistula jejunostomy, this is a video of the technique that is used for doing a Roux-en-Y fistula jejunostomy. We're going to look at a few of the subtle points in doing the Roux-en-Y fistula jejunostomy. Now, this is a patient with an acute leak. So it's both possible both in the acute as well as in the chronic presentations. So we're opening up the sleeve. You can see there's a lot of blood and inflammatory tissue from a recent procedure with a lot of infection. We open up the vital stitches that are still quite fresh, and you end up seeing this huge opening from potentially from an ischemic injury or a thermal injury at the G junction. And this is methylene blue coming out. So you open up the left, so now we're going to look at chronic leak. Now I'm going to show you the fistula jejunostomy with the chronic leak. I didn't want to repeat it in both videos. So giving you an idea of how the difference of the abdomen. So in a chronic patient, the inflammation is of a different nature. The momentum is harder. It's a little bit more fibrotic. It's not as hypervascular, but it is more hard. It's difficult to open. And so you open up, you're separating all that omentum from the sleeve because it's stuck to the sleeve, and you basically gain access to the upper G junction. Once you've got there, you do your endoscopy and you do your testing and you identify the site of the leak, and there's your site of your leak. You have to cut the edges and make sure you get bleeding edges. It's extremely important to get bleeding edges to do your anastomosis, and I tend to do the anastomosis with blood spurting from those edges, and this is something that was taught to me by Dr. Walid Bukhari, and I thank him for that. So you have to make sure there's blood spurting from those edges when you're doing that anastomosis. And so you prepare your roux limb and you take it up there and you start fixing it in interrupted stitches. So you do your posterior wall first, and then you do your anterior wall. You have to be careful not to compromise the lumen with the stitches. Unfortunately, you cannot place some sort of a bougie through this opening to make sure you don't close it. So you have to be extremely careful that you're not taking the posterior wall while putting these stitches. I tend to use PDS suture because it doesn't cause any injury, suture related injury to the anastomotic ends. There we go. Okay, so that was pretty much the last slide here. Okay, so in summary, laparoscopic sleeve gastrectomy is a wonderful bariatric operation that is quick to learn and reproduce and has good safety profile for patients, but the complications can be very costly, daunting, and sometimes difficult to deal with. And so you do need to have the essential laparoscopic skills and resources to make sure to avoid any unnecessary loss of life. All right, there we go. We've ended the webinar, and now